no, 2 weeks ago, we went through. I'll just go all the way to the start. So I'll introduce myself for those who don't know me. I'm David Ike. I'm a trainee at Cardiothoracic Surgery at Royal Papworth Hospital, and also co-founder of the London School of Cardiothoracics. London School of Cardiothoracics is a surgical teaching centre based here in London and connected to St Bartholomew's Hospital. Please just have a look at the website. We have lots of courses that we are doing if you're within the United Kingdom, and soon we should be taking this out of the country. Moving on from that, last week we decided to tackle cardiac physiology, and as I had said to Nifemi, the important thing for me was not to regurgitate the things that we could learn by picking up a textbook, or at the same time, none of us can compete with a cardiologist with regards to having any sort of discussion on cardiac physiology. But then I thought that we could approach the topic looking at it from the perspective of surgeons' need for information. And cardiac surgeons are probably cardiac surgery is one of the few specialties that needs a very strong medical foundation and medical knowledge. And therefore, what we've been trying to do with these sessions is to think about cardiac physiology while we are looking at our patients in the pre-op stage and in the post-op phase as well. And so we were tackling each aspect of this with regards to disease physiology, operative physiology, post-op, and complications. So at every stage, as I have shown in this slide, we are always thinking at the back of our minds, what is the heart doing? And if we know what the heart is doing, then we can intervene appropriately, right? And so, brief summary, we went through hemodynamics and related all of this to disease and valvular disorders and so on. And I think, if I'm not mistaken, Nifemi, we stopped somewhere during the cardiac electrophysiology slides. And I believe that I started to rush through these slides because I was hoping to finish the lecture on time. However, Nifemi was kind to say that we could have another week to finish these full slides before we even attempt to go into module 2. So what I will do is to go through the slides again very briefly, and at the same time starting from the from here, summary of cardiac electrophysiology, and I can then proceed towards the discussion in terms of applying this to disease physiology, applying this to pre-op, post-op phase, and also complications as well, and see if we can have a useful discussion on this. I'll be asking lots of questions during the lecture because I believe that we should be having a discussion, and we're not, that no one is a repository of knowledge. So I'll also want to be learning from you as you're learning from what I have to say in these slides this evening. Is that okay, Nifemi? Are you happy with this?
Yes.
Because I'll be proceeding to start now. Okay. So we definitely covered the hemodynamics in great detail, but I do remember I started to rush, and I've just gone through this. So I'll start again from this slide, and I'll go on to talk about when we're thinking about cardiac electrophysiology, we're thinking about the current, what's going on with the heart is it works. The foundation of how the heart works is action potential, isn't it? So how have we as humans decided to observe what the heart is doing? And so we'll start off with the ECG, and I think there is going to be a lecture on ECGs, if I'm not mistaken, so we wouldn't waste too much time on this, but this is a summary of both phases of the heart, so depolarization and repolarization. And we see that if we're looking at, I'm just going to pull my cursor. If we're looking at that, we have the P wave, which usually denotes depolarization across the atria. And we have the PR interval, which will show the initial depolarization of the ventricle. Okay. And we'll then look into the QRS complex, which shows the depolarization of the ventricles itself. Okay. So the PR interval is showing us the AV nodal conduction. And this is important because if we do remember, can someone tell me what is the sign on an ECG of a first degree heart block? And can someone post here on the chat? What is the first sign of an AV, a heart block of the first degree? Does anyone know what will be the sign on an ECG? Ifemi, I presume this is working, right? The chat system. Perfect. Prolonged PR interval. And can you tell me, please, how long that will be? No, that will be 0.2. Okay, so that will be 0.2. Okay, not 0.12, but 0.2. Okay, great. So, well done, everyone. So that tells us. So on an ECG, if we see a prolonged PR interval, which is greater than 0.2, then we know that that patient has a problem with their conduction system, and that will be the AV nodal conduction system. Now, the QRS complex shows the depolarization of the ventricles. A widened QRS complex tells us that there is a problem as well, right? And so usually we would say that, and this is where you have the 0.12 that you were talking about, but that will be in terms of the number of boxes that it will take on the normal ECG. So if you remember, each ECG box on the 15 millimeter ECG machine slide printout is 0.04 seconds. And so you're always expecting your QRS to hit a maximum of 3 boxes. If it starts to go wider than that, when we're thinking about widened QRS, a widened QRS starts to let us know that there's a problem with the depolarization across the ventricles. It could be that we have hypertrophy. It could lead to a lot of questions. It could tell us that we've got a bundle branch block as well. And so moving on, the QT interval is the entire period of depolarization and repolarization of across the ventricle. So we're talking about your heart is depolarized in the phase for systole, and now is going into diastole and is repolarizing at the same time. So in the QT interval is giving us a good look at that whole process. Now, we know that if we have a prolonged QT interval, then that could be dangerous. And you'd also see that a lot of medications that we give come with a lot of warnings about QT intervals. Why? Because if we have, and I think I mentioned this last time, so I'm not going to dwell too much about it, that a QT interval that is prolonged could cause us to have to start the point. And usually to correct this will be given a magnesium infusion. Now, the part of that we are most concerned about as surgeons is the ST segment, right? Now, the ST segment would always be something that we're looking at on an ECG if we've got an ischemic patient. Now, in the pre-op stage, obviously, if you have a STEMI, which is an elevated ST segment, that telling you that you're having myocardial infarction going on, or you could have an NSTEMI, which is also myocardial infarct that does not portray this elevation of the segment, but could also show us things like a depressed ST segment or a peaked T wave. And obviously, with the clinical signs of chest pain, or shortness of breath, or fainting, or syncope, and then having your troponin, which is higher than normal, depending on which troponin you're using. If you're using troponin I or troponin T, that gives you an idea of whether or not your patient is having an ischemic event. So ST segment is something that we pay close attention to. Now, in the post-operative period, if you look at an ECG, so you have a patient who has come in and you've done a nice graft to the lemur to LAD, you've done another graft to the circumflex, and maybe one more to the diagonal. The right coronary was fine, so you didn't touch it, and you're really happy with your case, and you're really happy with your case, and you decide that you are now going to your patient is in ICU. You've extubated. Day one, you appear and you ask for the ECG in the morning, and then you then see that this patient who had come in previously with an NSTEMI, and so there was no elevated ST segment, but now you see that there's global ST segment elevation. Are you taking this patient back to theatre? What's your concern? So every single lead on the ECG is showing an elevated ST segment. Can someone tell me what they will be thinking when they see this? Anyone? Can anyone answer the question I've asked? So now you've got an elevated ST segment across all leads. What would you be thinking about? Possibly on day one, usually day two, you see this sometimes. So this is a patient you've done a beautiful triple graft on. Any ideas? Would you be taking that patient back to theatre? No. Okay. Why? Not sure. Okay. If you have global ST elevation, you're thinking of pericarditis. Okay. So you wouldn't be taking your patient back to theatre because a global ST elevation will be pericarditis. Okay, so which is quite normal after surgery. However, if you have new ST segment elevation in any other lead that was not present in the pre-op ECG, then you're sending your patient to a cath lab because you want to check if you've had graft failure. And we know there are many reasons for graft failure in a CABG patient, but you have to have this at the back of your mind. So this is you as a registrar seeing your patients in the morning. You pick up the ECG. It's always very important to look at that ECG and compare it to the pre-op ECG. So you'd always request for both ECGs, and then you have to look and see where's the dynamic. Okay. If you see an ST elevation in one or two leads that was not there in the pre-op ECG, you have to look at your patient and think very carefully. Maybe I need to send this patient to the cath lab. We need to have a look and see what's going on. And especially if the patient is still on lots of infusions and is struggling to be weaned off noradrenaline and milrinone and so on and so forth. But if you see global ST segment elevation, you're not concerned anymore. Okay, that is pericarditis, and that usually resolves after a couple of days or weeks. So this is why this knowledge is very important, to have that in mind. And finally, T wave, ventricular repolarization. I always say T wave is very important because it gives you insight into multiple things. If you've got peak T wave and you have chest pain, that is a sign of angina. You want to be checking that patient very carefully. If you've got very peaked T wave with a flattened P wave as well, you're thinking electrolyte disturbance. So you're thinking high potassium. Okay, and this is something you would want to be careful. If you think you have a patient who has gone through surgery, who may or may not have, or most likely has renal chronic kidney disease, so they are quite susceptible to having electrolyte disturbances. Now, usually we want to keep the potassium between 4 to 5 for our patients. However, we don't want it to start going above 5, right? So the ECG is also, apart from your multiple investigations, your bloods, your ABGs, and so on, the ECG is also another way to look at whether or not you have a problem with regards to your electrolyte disturbances. And that a PT wave would give you that idea in the post-operative period. In the pre-operative period, it gives you an idea of whether or not you have ischemia going on. Okay, and negative T as well is another. That is when the T wave, instead of being positive, flips down, is negative. That also gives you some insight into ischemia as well. That should be investigated. Okay, so this is we're not going to spend too much time on ECG because I'm sure there's another lecture for it, but this is an overview, okay? And there's a method to my madness today. You'll see why all this information will come to play as we go further in the slides. Okay, finally, secondly, we'll go into action potential. Now, most people hated this. I hated this when I was in medical school. I hated to remember all of this. And so I have been very kind to just list it out and not start questioning everyone on what phase 0, 1, 2, 3, 4 is. I know some of you do remember. I know some of us don't remember. But I will take my time to explain this. But there's only one question I want to ask. This picture that I've shown, is this for a normal cell, cardiac cell, or is this for a pacemaker cell? So this picture graph that I've shown for the cardiac potential. Let me have a look at the answers. Anyone know? I'll show you the picture again one more time. Okay, so the normal cardiac cell in the ventricles, perfect. Okay, so that is what I'm showing to you. Okay, and so that means that the pacemaker should have a different picture, and I'll show you that. So we'll start off by talking about this. What is going on when a cardiac action potential is starting? So we know that, first of all, across the membrane at equilibrium, which is the equilibrium of potassium, the potassium channel, this is at minus 96 millivolts. Okay, so we're starting off from here. Now, when it receives the impulse, you have sodium channels that start to open. Okay, and there's an inward current of sodium channels to make the membrane more positive. Okay, now it is important that this is happening at minus 96 because sodium channels will not open if it's not this negative. So if this was at minus 50, you would not have sodium channels opening up and the influx of sodium ions, okay, across the cellular membrane. So at this value, at minus 90, they are activated. And then what you have is a very quick, and in this case, depolarization, right? And you get to, the membrane becomes positive at 52. And again, this is sort of an average value across all the cardiac cells that you look at in the ventricle. Now, at this point, you move on to phase 1. What we then have is the potassium ions starting to flow out of the cellular membrane, which is the brief period of repolarization. Okay. Now, what is happening is that the cell is now trying to revert back to normal. Okay, but remember, this is the ventricle we're talking about. The ventricle needs to contract for quite a long time. So, and that is because it needs to push out all that blood that it's receiving, it has received in diastole. It needs to push out all that blood into the systemic circulation. Okay, and so biology then thought, okay, what can we do to prolong that phase? Okay, we don't want to go back into, we don't want the heart to repolarize immediately, and so you then have calcium ions now coming in because he wants to keep this potential going. Okay, and so this is phase two. Okay, and that's why we have this plateau. So that is the logic behind it. It wants to keep the calcium ions are coming in to keep the membrane more positive, to continue that action potential. Okay. And then finally, in phase three, we then have multiple potassium channels opening. You have the slow delayed ones, you have the rapid delay ones, and that's all fancy stuff for the cardiac electrophysiologists. What we care about is that we know that potassium is now leaving, and this is in order for the cell to revert back to its negative the negative potential across the cellular membrane. Okay, and so there's an for that phase three, what you realize is that the calcium channels start to slow. Okay, and nothing ever happens in the heart immediately. So nothing's ever happening like that in a cell. It's all relative movement. So the conductance of calcium decreases, the outward current of potassium increases, and then you have that the resting membrane potential across that cellular membrane now reverting back to the normal, which is minus 96. Now, it is very important, as I've said, for it to go all the way back to minus 90, because once it hits minus 90, then it allows the sodium channels open up again so that they can repeat another action potential. Okay, so this is a summary, a short summary on this aspect of the cardiac electrophysiology. Now, we're going to talk about why every aspect of this is important and why this knowledge is important. Why? Because all the medications we use in cardiac surgery or in the post-operative, in the pre-operative, intraoperative, post-operative period for different forms of treatments all have used, they act at different sites, right? So it's either you would have heard of, medications called sodium channel blockers, you'd have heard of calcium channel blockers, you'd have heard of potassium channel blockers as well. And that is the whole idea. So if you have the knowledge of the action potential, and you're thinking about it from the point of view of what it's doing to the ventricles and the heart, how the ventricles are responding physiologically, you then have a better idea of why you're giving certain things and why you're giving certain medications, or what is the right medication to choose at the appropriate time. Okay, and we'll quickly talk about that. But before we do that, I decided to then test. Since you all know that that was not the graph for the pacemaker, I have now included one for the cardiac pacemaker cell, okay? But I have put no markings. So can anyone, now that I've jiggled your memory, can anyone tell me what are the phases for cardiac pacemaker cell? So here you have phase 0, 1, 2, 3, 4, okay? For cardiac pacemaker cell, what is it? How many phases do we have? Just post quickly. You don't need to tell me about it. Just tell me how many phases we have, and that's all. Okay, I'm waiting for an answer, guys. Okay, 3. Well done. Can you list them out for me? Total or pair? Okay, Christabel. Yes. Okay, what else? Okay, we always know that there's a depolarization and repolarization. But well done. You have done really well. So I'll go back to this. Okay, so what is different about a cardiac pacemaker cell is that you only have three phases. So while we talked about having um, 0, 1, 2, 3, 4. In the pacemaker cell, you only have phase 0, you have phase 3, and you have phase 4. Okay, and the idea for this is because, and I'll go back to that. If you look at that, this is a slope, right? This is the fourth phase. And the reason why we have that in the cardiac pacemaker cell is that remember that it's constantly depolarizing. So instead of having a trigger like the ventricle, right? Because the ventricle has to contract and then relax in diastole to receive blood, and then in systole contract again to push that blood out, and then repolarize and rest. Okay, so that's what the ventricles will be doing. But the pacemaker cells, they need to constantly be providing impulse. Okay, they need to be providing impulse to the heart to say, okay, this is we at rest. We need to maintain 60 to 70 to 80 beats per minute, depending on how physiologically fit you are. And so you need to go, we are sending an impulse now, and then another impulse, then another impulse. Okay, right? And then if you are having some sort of increased activity, exercise, or whatever it is, the pacemaker has to then go faster. So it needs to carry out that impulse faster. Therefore, it has to have a different physiological mechanism. And so the summary of cardiac pacemaker cell is that the action potentials are generated spontaneously within the cells. Okay. They have a constant resting potential that is steady depolarizing. So, and that is what you can see in this in here, right? Okay, you can see that here. And then finally, what we want to say is that they are also the fastest pacemaker cells will normally be the synatrial node. Now, can anyone tell me which other two aspects of the heart will have has the ability to perform pacemaker function? Which are the two sides? So I've talked about the SA node. The SA node is the one I've just talked about. So where else? The AV node and you're right. Peculiar, the AV node is one. Yes, the Perkin system. Perfect. Perkin fibers. Excellent. So they also have pacemaker potential. And why they have that is because if you have a problem with the SA node, then they will take, they can also have a steady depolarization potential, which then takes over the pacemaker function of the heart. Which is why when you have a patient who you've brought out from theatre and you've put a pacing box, and then you said to your registrar, the consultant says to you, I want you to leave this box on a backup mode. Okay, and then you have the heart rate of the patient at 80 or 90 beats per minute, and then suddenly you get a call from the nurses. Oh, my patient was the heart rate was at 90, but now it's at 50 or it's at 40, right? At that moment, you're running back to have a look at the pacing box and to make sure that the pacing box is working. And at this moment, what you know is that there's an AV conduction system has had a problem. So there's an AV block, right? So the normal pacemaker activity of the heart, which is a synatrial node, should not be giving you a heartbeat of 40 or 50, right? That is something that you'll find if the AV node has taken over that job, okay? And that is obviously not enough to maintain adequate cardiac output. So then you are then fiddling around with the pacing box to make sure that you have that. Now, if you, apart from this, if you have other drugs, something like beta blockers can obviously suppress the rate of the action potential of the pacemaker cells. So in the SA node, that is possible. But the doses that we give, you should not be seeing that go below 55 to 60, right? If you are giving your patient beta blockers to the point that they're reducing their SA, suppressing the SA node to 40 beats per minute, then you're doing something very wrong, okay? And very quickly, what we're talking about here is that the resting potential is at minus 60, and you have a slowly steady depolarizing potential that goes on here. And then here you have the IF sodium channels just in this upstroke. They open up, and in the same way that in the ventricular cells, they have an inward current. That's the same thing that you'll have here. There's an upstroke of activity, and then immediately after that upstroke of activity, then you have the potassium channels also doing their bit with moving out of the potassium current, increasing quite much more faster than you would have had in the ventricular cells. Why? Because you don't have phase 1 and phase 2 anymore. So you don't have calcium channel, the calcium inward current going on to elongate that potential. So you'd have that reach a positive of 10 millivolts, and then finally you have potassium leaving the cells to then repolarize this membrane and get it back to minus 60. And that's really simply how this is, how this occurs. Okay. So this is a brief anatomical picture of the heart, showing the sinoatrial node, showing the AV node, showing the right bundle branch, showing the left bundle branch, and then the two divisions, the left anterior and left posterior divisions. Okay. Now, talking about cardioregulatory centers and chemoreceptors in the medulla oblongata, this is one other thing to think about. Why? Because our sympathetic and parasympathetic nervous systems do impact the heart, right? And if we're anxious, we do find that our heart starts beating really quickly. When we're at rest and we're very calm, or we're meditating, we find that our heart's rate also slows down. So it's important to remember that you can have not just a subconscious, not subconscious, and unconscious control of the heart. That is when you're not doing anything about it, but you can also have a conscious control of your heart as well. You can get yourself into panic and increase your heart rate, or you can make yourself calm and reduce your heart rate. Now, how is the heart doing? How's the brain and the heart doing this? How are they connected? So we have baroreceptors in the internal walls of our carotid arteries, and we also have chemoreceptors in the carotid body, okay? And the sensory fibers that are there that measure things like output. So if your cardiac output is not sufficient, so let's imagine the hypovolemic patient, okay? The hypovolemic patient does not have enough cardiac output going into the aorta. So the baroreceptors in the internal carotid artery find that the pressure that is going through is just not the normal pressure that the body is used to. And then that sends an information to the brain, and the brain immediately is feeding that back to the heart and saying, okay, look, I want you now, through the sympathetic nervous fibers, I want you now to what? I want you to start pumping faster, okay? And the same with and so you have the parasympathetic fibers and the sympathetic fibers all feeding the SA node and feeding the heart as well. As you can see, the sympathetic nervous system is not only just feeding the SA node it's also feeding the heart as well, the heart muscle, which is also trying to give, which is an important concept. So you're not only asking the heart you're asking the pacemaker cells to do their job faster or to slow down, depending on if we're in our flight mode, or flight or fight mode, or if we're in our rest mode, okay? And finally, we also have sympathetic nervous fibers that go to the adrenal glands. and the adrenal glands will release epinephrine and norepinephrine. And what is the adrenal medulla doing this for? Well, if you have a situation where you have hypovolemia, what is the point of releasing epinephrine and norepinephrine? Because you want the heart to beat faster, because again, you're trying to maintain cardiac output. Cardiac output is a function of heart rate times stroke volume, if you remember that. So how do I improve cardiac output if there's any problem with the heart? I can either increase the heart rate or I can increase my stroke volume. Now, what is my stroke volume dependent on? My stroke volume is dependent on the preload or the afterload. So if I decide to, and what is my preload? That is the volume that is coming into the heart. And what is my afterload is the resistance that the heart is going to face when pushing out that volume into the circulatory system. So what my heart is thinking about, and then also at the same time, there's also Frank-Starling forces. That is the contractility of the heart. And if you remember, it's all about stretch. The more you stretch your muscle fibers of the heart, the more you're getting a stronger contraction. However, there's always a limit to how much that stretch will go, and that stretch will lead to a proportional increase in the force of contraction. Okay, so if you have that in mind, you automatically understand why the brain and the heart are connected in this way. So I give you a patient. Patient is hypovolemic, bleeding on the table while you're doing your operation, while you're closing. So you finish, the patient is off bypass now. And immediately you realize that you've come off bypass, and then the blood pressure started to return. And one of your grafts, unfortunately, it was done by maybe a junior member, and his patient has started to bleed profusely. And while you're doing that, you're asking to give blood products. Why? Because at that time, you're going to realize that even though you're coming off rest, you're going to see that the heart rate of that bleeding patient is going to go up. So the brain itself is going to start doing things for you that you as a surgeon can control, right? So it starts beating faster. Why? Because the heart is trying to compensate for that fall in cardiac output. Okay, the same thing with a patient who is post-op and is on ICU. If they're bleeding, you're going to see that they become tachycardic, and that's because the brain is asking the heart to beat faster. Because why? In that equation, if I increase my heart rate, I can increase my cardiac output. Now, what else can epinephrine and norepinephrine do? If we're looking at the afterload, if I can squeeze vasoconstrict around the body, then I can ask the heart to pump more, right? Okay, I can increase the blood pressure. And if I can increase the blood pressure in the system, I can increase the perfusion pressure across the different organs. Okay, and that is why we have epinephrine and norepinephrine being released into the system. And then if I can ask the heart to fill more in preload, then I can ask the heart to pump more as well. Okay, so these are some of the ideas of why the brain is connected to the heart in this way. Okay, so now that we've learned all of this, we'll now talk about why is this useful to us? So drugs affecting cardiac action potential. For sodium channel blockers, the most important drug here is flecainide. A lot of the medications here we do not use again. So we don't use quinidine as we used to. Procainamide has sort of been reduced in terms of its use. Lidocaine is rather used as an anesthetic, a local anesthetic. This is why also when you're giving local anesthetics, that is lidocaine as a local anesthetic to reduce pain for any procedure that you may be conducting. So this could be putting in a central line or putting in an arterial line, depending on the pain threshold of the patient. There's a certain amount of lidocaine per kilo that an anesthetist must give. Why? Because if you start going above that amount, then you're very likely to suppress the sodium channel, and you can actually cause a cardiac arrest. And this is why it's very important to keep that in mind. And if I'm not mistaken, it's about 5 milligrams per kilo. That's the maximum lidocaine amount that you can give for a local anesthetic. And if you and that can slowly go up to 7 milligrams if you use the the medication, the lidocaine, that has a bit of adrenaline infused into it. So there's a mixture, very weak. So that helps negate some of the suppression activity on the sodium channel. So this is just to keep that in mind. Flecainide we use as a pill in the pocket, and we normally use that in patients who have got paroxysmal AF. And if a patient who has got paroxysmal AF and maybe has AF and goes into atrial fibrillation every now and again, then you can give them the pill in the pocket. So they hold that, and when they start to feel the palpitations, they take it, and its method of action is a sodium channel blocker. Okay, so we move on to class 4. The class 4s are the calcium channel blockers. So we have verapamil, diltiazem. These are mostly blood pressure drugs. However, diltiazem is also used for vasodilatation. So I'll first of all focus on it as a channel blocker for blood pressure. Then I'll focus on it also as a mechanism for vasodilatation. So as a channel blocker for a lot of hypertensive patients, we use verapamil and diltiazem. And the idea is that if you relax you can slow down the heart rate. That's number one. And number two, you can also relax the force of contraction. And this is the idea of blocking, having calcium channel blockers. You also have amlodipine, which is also a calcium channel blocker as well, being used in hypertensive patients. And diltiazem has also found use in radial artery grafts. So radial artery grafts, as you all know, smaller diameter, can still give you the same benefit of a lemur, but is very prone to vasoconstriction. And so these patients then end up having diltiazem, 90 milligrams BD, if you've done a full arterial revascularization and then using a radial artery graft. And so that's another use for that. Potassium channel blockers, we've got amiodarone and sotalol. Everyone knows about amiodarone. It's the thing that we love when we have patients in AF, especially if this is a patient who has had new postoperative AF. You're starting them on an amiodarone infusion. You start them off with between 300 milligrams stat, and then you continue a 900 milligram over 1 hour, and you continue with a 900 milligram infusion over 23 hours. So they get a maximum of 1,200 milligrams of amiodarone over 24 hours, and you're hoping that when you give this to them, they revert back to sinus rhythm. And now, when you think about it, you know that the reason why this is happening is because you are giving them a potassium channel blocker, which should sort of help flip the heart back into sinus rhythm. Okay, and then finally we have class 2 drugs, which are beta blockers, and we can see that propranolol, metoprolol, beta blockers have a huge range of action. Not only are they acting on potassium channels, and they're called potassium channel rectifiers. Please ask the cardiologist why they name it that way. But then also they affect the nervous system. Right, so the beta blockers also affect the nervous system, and they help reduce sympathetic activity, or modulate parasympathetic activity and signals to the heart, which usually ends up with controlling the heart rate, suppressing the pacemaking potential of the heart, and also reducing force of contraction. And this affects things like blood pressure. Okay, so if you're hypertensive, relaxes the heart and enables the heart to feel better in diastole. Now, when the heart is feeling better in diastole because there's more of a prolonged heart rate, what's happening is that you are also feeding the coronaries as well, because the heart feeds itself. So the coronary arteries are perfused during diastole, right? So the longer your diastole occurs, the longer your coronary perfusion occurs, which means that the myocardial oxygen demand is met. And this is how you affect ischemia. Okay, so by improving coronary perfusion, in diastole. By allowing the heart relax and feel properly, you allow the heart muscles get the oxygen demand, or the oxygen demands, you ensure the oxygen demands are met. And this is how you enable the heart to work appropriately. Okay. So as you can see, knowledge of all of these that we've talked about then gives you a clearer picture of what the drugs we give are actually doing. And now we go into my favorite aspect, and I've just realized that it's 7 o'clock. Cardiopulmonary bypass. Okay, I really wanted to play a video, but I know that Nifemi has told me there's going to be a lecture on cardiopulmonary bypass, so we're not going to talk about cardiopulmonary bypass, the circuit, and so on. But the most important thing that I want to pick out here is you'll have, for those of you who have done surgery, you know that we cannulate you have venous cannulation. There's a venous reservoir, and by gravity, blood is sucked out of the body into this venous reservoir. It goes through all the heat exchangers, oxygenator, and it goes, which oxygenator acts as the lungs of the artificial lungs, and you then feed that back into the arterial filter, back into the system, back into the aorta, and into the circulatory systemic circulation, so you can perfuse all the other end organs and the brain, while the heart, you have a bloodless and munchless field. So the idea of cardiopulmonary bypass is to ensure that you can work on the heart and still perfuse the rest of the body, but while you're working on the heart is not moving, and the heart is, there's no blood in that field. Okay, so the most important thing here that I want to talk about is cardioplegia. Okay, so cardioplegia is the way that we stop the heart, and thinking about cardioplegia, and I've brought that back again. So if you know your knowledge of what we've talked about, give you an idea of actually how cardioplegia works. So cardioplegia has a high potassium concentration. Okay, and so when we give cardioplegia in surgery, we are causing an increase in the extracellular potassium. Okay, which means that you still have depolarization go on, and you have repolarization going, but when you start trying to repolarize the heart, so you have this plateau here in phase 2, but which you remember is calcium coming into the cells, okay, and trying to elongate that depolarization. But when you get into diastole, which is repolarization, what you then have is, because the cellular membrane potential is much less negative, right, because you have all these positive potassium ions in the extracellular matrix, the heart then arrests here in diastole. Okay, so the heart arrests in diastole, and it cannot repolarize. Why? Because it does not reach the minus 90 millivolts that should instigate sodium channels to open again. Okay, and the key thing here is, because you're arresting the heart in diastole, you're not using ATP. So then there's no oxygen demand, the heart stops, and then you can work on and sodium channels are inactivated, and then you can work on your heart for as long as you can. Now, this is obviously, as you're performing surgery, it will wash out of the system, and you would have to give it antigrade or retrograde, as the case may be, but you'll have to keep giving cardioplegia and at various points intermittently during your surgery. Okay, and the other thing to do is cardioplegia is normally given cold. Most people prefer to give it cold. Why? Because if you give it cold, hypothermia means that there's a reduced metabolic rate of the tissues involved. Okay, pacemakers. Now we've talked about. Remember when we talked about the anatomy of the pacemaking, the SA node, the AV node. What does a pacemaker do? The pacemaker is only substituting the function of the pacemaker cells. So if your sinoatrial node has a dysfunction, then your pacemaker can come in and do the job for you. Okay. Now, again, Nifemi has let me know that there's going to be a lecture on pacemakers, so I have decided not to go in depth. It's a topic I like, and so I can wax lyrical about this for as long as possible, but I will just say that very important to remember for pacemakers. What are we thinking about? There are 3 positions that are important to us. As surgeons, we don't really care about the 4th and 5th, because that is what the cardiologists care about, but there are 3 positions to remember, and there are three modes that are important for us. So the first letter in a pacemaker mode tells you the chamber that is being paced. The second letter tells you the chamber that is being sensed. The third is what the pacemaker will do when it responds to that. So if you have AAI, it means if you've ever seen a mode or the consultant has told you, I'd like you to put this pacemaker on AAI mode. What they're saying to you is they want the atria paced, they want the atria sensed, and when that is sensed, the pacemaker will inhibit its activity. Okay, so when would we use an AAI mode? We'll use an AAI mode in the sense when we have a patient who has come out of a nice triple or quadruple bypass, and you are quite fairly certain that the AV node you've not done anything to the AV node. You have not been naughty at all. And you're only pacing the patient because either they have, it will take time obviously with local information and so on and so forth, or if they had the right coronary issues, they may have some sort of sinus node dysfunction. And so you would want to give them an adequate heart rate, which is anywhere between 80 and 90 beats per minute. And you also want to ensure that they have a good cardiac output. Remember, I told you cardiac output is heart rate times stroke volume, right? So in order to pace them artificially, you put them on 90 beats per minute, AAI mode, and this tells you that your atria is both atria are being paced. Both atria are also being sensed. Why are they being sensed? If, for example, the intrinsic activity of the heart recovers after 24 hours and starts to outpace the pacemaker, you want the pacemaker to stop, right? You want the pacemaker to stop its activity. Why? Because if the pacemaker continues its activity when the heart has recovered its intrinsic function, you can have something called the arrow on T phenomenon, where the pacemaker is giving an impulse on the intrinsic activity of the heart when the heart wants to relax, and that can cause ventricular fibrillation. Okay, so just to keep that in mind. And then, so we're using this AI mode is normally used when you think there's a bit of sinus node dysfunction. You want to ensure cardiac output, and you're very certain that your AV node, there's no problem with your AV node or conduction system. Okay, then you have VVI. VVI is the same thing. It's the same thing, but you're talking about a different chamber. So you're talking about the ventricle. So you're pacing the ventricle, you're sensing the ventricles, and your response to the ventricles is either to inhibit. I've written T here. T also means trigger a delay. Okay, trigger a delay means that the pacemaker itself is going to pause for a while and decide whether or not it sees that there's intrinsic activity in the heart happening, and then it would, based on that information, decide whether or not to provide some impulse or not. Okay, and then you have the dual mode, DDD. This means that you are pacing both chambers, so the atria and the ventricles. You are sensing the intrinsic activity in both, and then when you do, your response to sensing is either to inhibit or trigger a delay in both chambers. Okay, so this is the simple concept of pacing. All it's trying to do is replace the function of the sinoatrial node, or in the case may be to do that, replace the AV node as well. And so when do we use VVI? We use VVI as a backup if we think our patient is going to flip from atrial fibrillation back into normal rhythm, or we also use it in the case where we think, when we think that we may have a problem with our AV conduction and we want the heart to be protected. So we know that, I'll give you an example. Your patient has come back from theater and this is day one, has gone into AF, and you start an amiodarone infusion. Now remember, you're giving them both amiodarone and beta blockers. And we've just said to you that amiodarone is a potassium channel blocker. Beta blockers are also potassium channel rectifier, and can have blocking activity and suppress the pacemaking function of the heart as well. So you're giving two medications that have those activities on the heart. So what are you going to be doing in this case? You want to protect the patient. So when in AF, your problem is not the heart rate, because the atria is sending about close to anywhere 300 beats per minute. When it gets to the AV node, it's slowed, it's halved, and so what you see is the heart the heart rate is going at about 150 beats per minute, but then you give amiodarone and that can now flips that back into sinus rhythm. However, because you're giving amiodarone beta blockers, you can flip it from sinus rhythm into an AV conduction block. And if you do that, if you're pacing the heart at AAI, the ventricles will not receive any impulse. And so what you'll do when you put it on VVR, you're putting a backup system to say, okay, if my heart flips into AV, a heart block, a complete heart block, the heart is protected, and the VVR will ensure that some impulse is provided to the ventricles for it to work. Okay, and then DDD is a dual mode, which basically helps you coordinate the function of the atria and the ventricles together. Why is it important? If you're pacing the atria and the ventricles together at the same time, you have the best protection possible. But also in patients who have a cardiac output problem, you get that 20% atrial kick that you can give in atrial systole. Okay, and so you are improving the output, and this can be very dramatic. Also, you're improving the coordination between the atria and the ventricles of the pacemaker itself, okay, of the pacing box. Why do I say that? You can set a DDD mode in such a way as to ensure that if the atria, if it gives an impulse to the atria to then push that impulse all the way into the ventricular system, you can program a delay when it gets to the AV conduction system and say, okay, you know what, pacemaker, I want you to have a prolonged PR interval of maybe 240 or 250 milliseconds to give the heart enough time. So if the heart starts to recover its own function, it can bring out its own intrinsic ventricular activity. And this is why we use DDD. So this is just a brief summary of pacemakers. What I'm talking about it because I have talked to you about cardiac electrophysiology, and this is the application of it in our work as surgeons. Okay. And how many slides have I got left? Okay. So I'm not going to waste too much time on this, but we know because I'm going to talk again about this when we go into cardiac output, ICU, and so on and so forth next time. So I'll do a deeper dive. But we know, obviously, that there are different receptors in different aspects of the vasculature and our end organs as well. And we know that there are medications that we use, norepinephrine, epinephrine, dopamine, vasopressin, and we'll be talking about those in terms of the infusions that we use next time, because next time I'm going to focus on cardiac output, all the lovely formulas we have, and that will be module 2. Okay, so this was just meant to sort of introduce the concept, the use of dobutamine, dopamine, epinephrine, norepinephrine in the cardiac patient. And so we know that there are vasoconstrictors, there's noradrenaline, there's vasopressin. We know that there are inotropes like phosphodiesterase inhibitors, milrinone. What do? They improve cardiac contractility, but they also have vasodilatory effects. Adrenaline does everything. It's a horse whip, and the horse is the heart. Adrenaline is the whip, and it whips the heart in so many ways to ensure that it can provide output, but then it's not without significant side effects and complications. Okay, now this was my last slide before we go into the next aspects of our lecture next week, where I will finally talk about cardiac muscle, cardiac output, and that will finish off this whole series on cardiac physiology. The routine postoperative management for a patient. On day 0, you have your first hour in intensive care of your patient. Your goal is to ensure early extubation of your patient and then continue routine ICU management. You have to be thinking as a surgeon, what do I need in terms of cardiac physiology that's going to help me provide the best care to my patient? And now we've talked about hemodynamics, we've talked about electrophysiology. Next week, we'll talk about cardiac output, and we're going to be talking about all the factors that you'll have to be thinking about when you're treating that patient in that first hour in intensive care. Okay. Not only in the first hour intensive care, you're also thinking about when you're bringing out the patient we're taking the patient off bypass. We already talked about cardioplegia, which is an important aspect of bypass. But what else are we thinking about when we're bringing out a patient, when we're taking the patient off bypass? What are we thinking about in terms of blood pressure, regulating blood pressure? What are we thinking about in terms of reducing metabolic activity so we can reduce myocardial demand? Because the last thing we want to do is cause infarction while we are taking our patient out of bypass. Okay, then we'll talk about day one. When your patient has gone through day zero, what are the things that you're thinking about in terms of what medications do you want to start your patient on, and what is the physiology of that helps us know why we will start beta blockers, why are we going to start, why are we going to wean off very quickly all the support. What are we thinking about when the nurses tell us that there's a patient whose blood pressure is low and they're concerned? Okay. And then day two, we start taking out a lot of wires. Why don't we need any of these monitorings anymore? Why are we taking the catheter out? Why are we taking the central lines out? Why are we disconnecting the pacing box? And if we do all of these things, what are the safety what's the safety net we leave for the nurses as well who are taking care of our patients? Okay. And day three, we have pacing wires out, mobilizing the patient. We're starting AC inhibitors. What is an AC inhibitor doing in the physiology of not just because renal physiology is very closely tied to cardiac physiology as well. But AC inhibitors, with angiotensin converting enzyme inhibitors, also have direct effects on the heart. And what aspect of cardiac physiology is that related to? Okay, so I want you to have this picture to think about your daily practice, to think about when you go home today, you're working for the rest of the week, think about all of how cardiac physiology can help you in the routine post-operative management of the patient. And then next week, when we come together, we'll finish off this module. And I hope this has been useful to you. Again, I did not want to talk about things that you could find in the textbook. Rather, I wanted to approach this in terms of utility, what's most useful to the junior surgeon. Okay, guys, that's the end of my lecture, and I do wish you a lovely evening. I won't be able to take any questions, but if you type your questions, and Femi can forward them to me. Okay, I hope this has been useful. Thank you very much for your time.
Thank you very much, David. I know we started quite late, so we just about an hour in actually. Thank you very much for that comprehensive teaching, and our time is gone. So I will just say that I've sent the feedback form on the chat. So feel free to provide the feedback, and so that you can get your certificate of attendance after filling the feedback. That's one. Number two, if you have any questions for this session, I know we don't have time for questions. You can note it down, and in the next session, we might just take a very brief 10-minute session of questions and answer before we go into the teaching on cardiac physiology for that day. So feel free to note down your questions if you have any questions on this session. I know a lot was said. Even I myself have questions. So feel free to note it down. And just to announce that I mentioned in the beginning of the session, we are going to have another our fifth session on the teaching series, which is titled Pacing, Arrhythmia and Pacing in Cardiac Surgery. So he has done a sort of brief introduction to pacing and arrhythmia in cardiac surgery towards the tail end of his lecture today. And on Saturday, 6 p.m., we will be continuing on that. The teaching session is going to be taken by another person, not by David. But feel free to attend. The link is the advert for the session if on the medal page, on the SIGAV medal page. So you can check it out and sign up for it. Thank you everyone for attending. I hope you had a wonderful time and you were able to understand what was being taught. And hopefully I will see you on Saturday for the pacing and arrhythmia session. Please sign your feedback forms. Thank you. Data, if you can note your question down, and in the next cardiac physiology session, we'll be able to answer that. So just note it down on a note or on your phone, and we will have a question and answer session in the next session. Thank you.